Good afternoon, evening, or morning, depending on what part of the world you are joining us from, and welcome to the 2023 Open Summit, Day 2. On behalf of the Ontario Pharmacy Evidence Network, Open, and the Centre for Practice Excellence at the Leslie Dan Faculty of Pharmacy at the University of Toronto, it's my pleasure to open today's Open Summit. Next slide, please. My colleague, Annalise Mathers, the administrator for the Centre of Practice Excellence, and I welcome you to the Open Summit, an opportunity to learn, collaborate, and share, and an opportunity for all of us to learn more about the diverse array of practice research interests that are represented by our group and the work that is being done, not just in Canada, but internationally to support better patient care. Next slide, please. This is day 2 of our 2-day virtual summit. Those of you who are able to join us on February the 14th for the topic on digital health technology and virtual care in pharmacy will know that our format will involve a keynote speaker, followed by oral presentations, but most importantly, lots of opportunity for questions, answers, and interaction. The summit is brought to you by the Ontario Pharmacy Evidence Network and is hosted by the Centre for Practice Excellence at the University of Toronto. Next slide, please. Prior to beginning, I would like to first acknowledge the traditional territory that I am seated on and that many of you may be seated on, includes the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and this land continues to be home to diverse First Nations, Inuit, and Métis people. Depending on where you are seated, you will have different acknowledgements to make, and I would invite you to provide your own acknowledgements in recognition of the land and the commitments made to those peoples. Next slide, please. As I hope you all know, and if you don't, let me be the first to tell you, Open is a team of multidisciplinary researchers working together to evaluate the quality, outcomes, and value of medication management services that pharmacists and other healthcare professionals provide. As part of our commitment to our diverse communities, we are fostering knowledge translation and exchange in order to build capacity in medication management research to address the needs of Ontario's vulnerable populations. Today's event is part of our commitment to ensure the ability to share and to allow individuals to learn from one another. I see in the chat that we have guests joining us today from New Zealand. And so kia ora to you, Megan, and thanks for joining us. Next slide, please. The Centre for Practice Excellence at the Leslie Dan Faculty of Pharmacy generates and utilizes leading-edge medication management research and innovation to drive diverse programming. And we invite you to consider joining our network and attending many of our events, including our very popular monthly speaker series activity. Next slide, please. Before turning it over to Annalise to introduce our speaker and to get today's activities underway, just a quick note that we will be audio and video recording today's session, and the recordings will be available on the CPE website shortly after this event. We invite you to refer to it and to refer those who would be interested to who were not able to attend today to access today's program. We will be moderating the question and answer period and so we invite you to use the chat box feature in Zoom to ask questions or provide any comments or constructive feedback. It will allow us to sort of manage time and keep things orderly and effective for the hour and 45 minutes or so that we will be together. With that, let me turn it over to Annalise to continue to give you some idea about what we're going to be hearing today and to, of course, introduce our keynote speaker, Professor Claire Anderson. Over to you, Annalise.
Thanks so much, Zubin, and welcome to everyone who's joining us online. I'm just going to take our slides down so Claire can put hers up just as I introduce her.
You're going to put them up for me? Yeah.
I can.
Yeah, sorry, please. Yeah, that's why I sent them. Thank you. Sorry.
Yeah, give me 1 minute. I'll multitask. I'll hold the slides up and then also just give you a warm introduction as well, Claire.
Sorry.
Perfect. Okay, I'll throw those up in just a second. So we're really fortunate to have Claire Anderson joining us today as our keynote presentation. Claire is a professor of social pharmacy in the Division of Pharmacy Practice and Policy at the School of Pharmacy at the University of Nottingham. She's president of the Royal Pharmaceutical Society. Her research has led and informed the development of pharmacy and pharmacy education in the United Kingdom and globally in public health, influenza vaccination, prescribing, and pharmacists in general practice. As an internationally renowned social pharmacy researcher, she's shaped the future of global research in this area. She's also set the agenda in pharmacy education research and development through prestigious work with the International Pharmaceutical Federation, or FIP, since 2002. She's also a trustee of the Commonwealth Pharmacists Association. We are very, very fortunate to have you with us today, Claire. And I will just share my screen so that you can take it away for your presentation.
Thank you.
Let me just see, it's just loading.
That's lovely. It's just when I do it, I can't continue to see people, so I don't know why. I
Great.
thought it was easy for you to do it. Thank you. Is it going to go on to slideshow?
Oops, I can see it on my end. Are you able to see it?
It's not on slideshow. It's still got the side bit. I don't seem to be able to do anything with it.
I think, is that
Oh,
good
now it's okay. Yes, thank you. Sorry, everybody, and thank you very much for the kind introduction. It's lovely to be here and talk to you. I've been asked to talk a little bit about community pharmacy in the UK and some of the things that are going on there. So without more ado, I shall start. Yes, so as you know, the UK is divided into different countries, and actually the Royal Pharmaceutical Society only covers England, Scotland and Wales. I'm based in England and know more about England, but I'm going to tell you a little bit about what's going on in Scotland and Wales, and you'll realise why, because quite exciting things are going on there. But I'm going to focus on England for some of the stats and some of the basic stuff just to tell you, and then you'll start to see the differences between England, Scotland and Wales. So there's just over 11,000 pharmacies in England, community pharmacies, and about half of those are owned independently. That means somebody might own 5 or 6 pharmacies, but they're not the big multiples like Boots and Lloyds and Superdrug and so on. And the community pharmacy actually represents a very small proportion of healthcare costs, despite its increasingly important and well-used role. Our funding is actually quite small, as you can see. It's only 2.3% of the total NHS England spend, but we manage and procure the dispensing of £9.1 billion worth of medicines in primary care, which is 8.1% of total healthcare costs. So there's a bit of a mismatch, and there's a lot of campaigning going on at the moment regarding community pharmacy contract and how they are paid, which the Royal Pharmaceutical Society aren't involved with as the professional leadership body, but we're supportive of having better working conditions and so on for pharmacists, because that impacts on patient safety. In England, we have different types and levels of pharmacy services. So we have essential ones that everybody has to provide, which are listed on this slide. So obviously dispensing medicines. We have a discharge medicines service whereby patients being discharged from hospital, the community pharmacist is informed and can do a medication review with that patient when they come back to the community. And you can see some of the other things that we do. I'm sure they're very similar to what goes on in Canada. Sorry, your slides on. Oh, there we go. And then we have advanced pharmacy services, which happen in England. We have the community pharmacy consultation service, whereby pharmacists receive referrals either from our telephone triage service, which is known as NHS 111, or from general practice. for minor ailments, and then the community pharmacist can do a consultation. The patient gets told to go to the pharmacy rather than anywhere else, and the pharmacist does a consultation with the person, and the pharmacist gets paid £14 per consultation, has to keep a record, etc. And then they can sell an over-the-counter medicine. But it's been quite heavily criticised, and I'll talk about that in a moment. There's the flu vaccination service, hepatitis C testing service. I've just read before I came online that that's going to stop from April the 1st. I don't quite know why, but so ignore that one. Hypertension case finding, the new medicine service, which I'll talk about in a moment, and smoking cessation service, where again, people are referred from hospital to stop smoking. So next slide. Sorry, there's a, yeah. Okay, so then on top of all the advanced services and the essential services, we can also have what are called locally commissioned services. And they could, I've put some on there, just some examples. They could be anything. Of course, COVID vaccinations were commissioned right across the country, but they're still a locally commissioned service. All sorts of other things happen as well. Needle and syringe exchange, supervised consumption of methadone, other contraception services, both for emergency contraception and ongoing contraception. And ongoing contraception is about to become an advanced service as well. It's all in a state of flux. So to provide an advanced services, pharmacists have to have a consultation area. Their actual premises has to be accredited. More than 95% of pharmacies do have a consultation area now. And for many of the services, they have to show that they're competent and have additional training. The new medicine service is a long-established service, which is paid for and delivered across the country, across England, offered by nearly all pharmacies. And it's about improving adherence to medicines. Patients prescribe their medicines as normal with advice, but are offered a consultation with two or three weeks later, either in person or over the telephone. And pharmacists are paid £20 and £28 for each service, depending on how many patients they give the service to per month. And my colleagues at Nottingham did a randomised control trial that showed that 10 weeks after receiving the consultation, patients were more likely to take their medicine or sought further help from their prescriber compared with the control. And 7 in every 10 patients who received the service took their medicine, compared with 6 in every 10 in the control group, and economic modelling showed that it was cost effective. And it covers these medicines, and antidepressants are about to be introduced, but it's long covered the other ones since the start. So various different medicines. So one of the other things, as Annalise said in the introduction, that we've been involved in is flu vaccine. There's meant to be some more things coming on this slide. I don't know. I think it's because I'm controlling it from Oxford and you're in Toronto. So we did a lot of research on flu vaccines in pharmacy, which led to the vaccination being a paid for service from pharmacy. We showed that it was easier in pharmacy. Some patients prefer to pay for flu jobs rather than using the NHS service, but that led to the NHS service being provided to people free of charge from the pharmacy. And of course, that laid the basis for COVID vaccinations in pharmacy as well. and our work influenced work across France, in Australia, and in various other countries as well. So it was quite high impact research. I've already talked about the community pharmacy consultation service. So I'm going to skip that slide. Right. So just to tell you about what goes on in Scotland. So Scotland have a devolved health system compared with England. They have far fewer pharmacists, only between 2,000 and 3,000 actual pharmacists. And community pharmacies there have this wonderful service called Pharmacy First Scotland, and they can offer treatment to patients presenting with certain minor conditions such as sore throats, earaches, and so on, and UTIs. And they don't have to go anywhere else. They can self-refer. And as you can see, over 500,000 consultations were carried out between January 21 and March 22. And some resulted in a referral to the GP, but more than 400,000 were for a consultation that resulted in a medicine being dispensed. So saving a lot of time for patients, freeing up general practice and local accident and emergency departments for non-urgent treatment. There is a formulary, and pharmacists get a base payment of £1,250 a month, plus more depending on the level of activity. However, in Scotland, they have really pioneered training independent prescribers. So many of the community pharmacies now provide a service called Pharmacy First Plus Scotland, and they get £2,000 a month to prescribe more widely for common ailments. So in Scotland, many more people are going to the pharmacy for common ailments than previously. In Wales, they've gone a step further. They have the Clinical Community Pharmacy Service Wales, and they sign up to provide a variety of services: emergency contraception, bridging, and quick start. So bridging from emergency contraception through to progestogen-only contraception, as well as starting somebody off on progestogen contraception. Flu and COVID vaccine, common ailment service. So again, a bit like the Pharmacy First Scotland, and they can supply medications in emergency for people without having to charge them. Under the service, again, similar to Scotland, many community pharmacists in Wales are now independent prescribers and can prescribe for minor conditions and routine contraception. And they have secure access to the patient's Welsh GP record, and that makes all the difference. This is me visiting a pharmacist in rural West Wales last year, who said that his whole life and practice had been changed by being able to be a prescriber, to have the link into the primary care record of the patient, and to be able to deliver these higher level consultations. For example, being able to prescribe antibiotics for urinary tract infections and all sorts of other things. He said he felt empowered and excited to be a pharmacist for the first time. And many consultations delivered monthly, and 97% of people said they'd have visited another healthcare provider had the service not been available. So again, keeping people in the community, keeping people away from hospitals and urgent care centres and general practice, and really using pharmacists to the best of their ability. Just to show you, if you're interested, that's some of the funding for Wales there. So it depends how many hours a month they do, and it might vary. So, but they get quite good funding and per consultation. So there are differences in impact across community pharmacy in Great Britain at the moment. Quite big differences going on, and it's quite an interesting time. We have quite a big problem with closures of pharmacies. It's become increasingly hard in England, particularly, to actually afford to run a pharmacy, given all the issues with the low level of payments that pharmacists get, with the pressures that they get, and with the downward pressure on prescribing, on dispensing, and the amount of money they get for that in the contract. And also workforce issues. So there's workforce issues right across the 3 countries. There is a massive shortage of pharmacists. Brexit has probably contributed to that, as well as other things. One of the other things is a lot of our pharmacists work now in general practice. That's been a very well-funded, supported service by government. So many pharmacists have moved out of both community pharmacy and hospital to have funded positions in primary care, working in general practices, and that has led to workforce issues as well. We have a workforce issue right across the National Health Service, and I think COVID contributed to that, because people started using pharmacies much more, but it wasn't in Wales and Scotland. Pharmacists did get more money for that, but in England they didn't. We are waiting to hear in England, and we will hear next week, because there's 2 big reports coming out next week. There's a review of primary care and what goes on in primary care altogether, including pharmacy. And there's the big review of the NHS workforce coming out next week. And people are saying that we might move to pharmacy first in England, but nothing has been confirmed. So we still don't know if that is going to happen. At the moment, we have the Community Pharmacy Consultation Service, which is, as I said, it has extra layers which it doesn't need, where patients are referred, whereas the 2 systems in Wales and Scotland, patients can self-refer. In Scotland and Wales, again, they have increased prescribing. England are way behind, and that is beginning. So they're beginning to fund more pharmacists to become prescribers in England. At the moment, you have to do a 6-month university course. You don't have to go for 6 months. It's a course over a period of 6 months, and you have to have a mentor who's already a prescriber, who doesn't have to be a doctor anymore. They can be a nurse or a pharmacist or another prescriber. But the biggest change that's happened is students who started our MPharm course, which is the equivalent of your PharmD, they who started 2 years ago, so students who are now in the 2nd year of our course, they are going to do their 4-year university and 1-year internship and come out as fully fledged independent prescribers. So massive change. We've had to change the course. So the future is much more clinical, I would say, but it's at different stages. Oh, sorry, can I go back? Yeah, NHS funding, again, England have more issues with lack of funding than Wales and Scotland. Wales and Scotland have been much better funded. And again, technology varies. Wales have less problem than the others. I won't dwell on that. Okay, next slide. Okay, so the final things I wanted to show you is that we've been developing visions in the Royal Pharmaceutical Society for pharmacy. This is a summary of the Scottish vision for pharmacy. all about a cultural shift from medicine supply to clinical focus, recognizing community pharmacists as clinicians, and improving medicines use, treating common clinical conditions that I've been talking about, as well as managing long-term conditions. So not just using independent prescribing for treating common conditions, but actually prescribing for long-term conditions as well, having a caseload, maybe say prescribing in diabetes, hypertension, something like that. And to achieve the change, you do need to have the workforce infrastructure, you need enhanced skills, you need clear career pathways, and I believe you need credentialing of career stages to enable professional fulfillment along the way. And in Scotland, they have done more on credentialing with the Royal Pharmaceutical Society than perhaps the rest of the country put together. And we've been campaigning for protected time for learning as well, because most other health professionals in the UK get protected time for learning, but pharmacists don't. So managing medicine supply, much more, that pharmacists won't be involved in that. And having a shared electronic record with read-write access for all, offering patient-facing digital services as well. Wales have developed vision, but I won't talk about that today. And in England, we have worked with the King's Fund, who are an independent body who look at health issues in the UK. Wonderful body. It's been amazing to work with them to develop the vision for the pharmacy professional practice in England. And that QR code on there will lead you to that vision, or you can Google it. I think the slides will be available afterwards. So our vision in England was based on the fact that COVID had generated rapid change, health inequalities were being highlighted and exacerbated, and community pharmacies provided consistent access, and pharmacy teams led a system-wide vaccine rollout, providing expertise and resources. And other changes, there's been a massive change in NHS structures. They're always changing it. They probably do the same in Canada. Changing workforce, so the change towards prescribing, the development of pharmacy technicians' roles and support staff roles, and changing models of service. And that it seemed an opportune time to develop a vision. So our vision is divided into person-centered themes and enabling themes. I haven't got time to go into it, but I do commend it to you. So supporting people and communities to live well for longer, enabling people to live well with the medicines they take, and enhancing their experience and their access to care. And we talk about our pharmacy people, our workforce, data innovation, science and research, and leadership, collaboration and integration, which all enable the above to happen. So please read our visions. So how do we make change? I think we need to do a number of things. We need research evidence. So often now, our policymakers, they even commission research and then go ahead and do something before the research is finished. But I think the more evidence we have that something's working, the more likely it is to continue. And we need good, strong evidence. We need health economic evidence as well. We need successful partnerships with policymakers and service commissioners, and professional bodies like the Royal Pharmaceutical Society, I think, play a very important role in bringing people together, in driving change, in advocating change, in talking to government, in talking to media and so on. And I also think that if people are going to change in their individual practice, it's very important that they have good role models and good mentors, and can see somebody who's already doing something, and realize what's possible for them. And I think that really helps people to change. So what's happening in community pharmacy this year in the UK? An awful lot is happening. Pharmacy closures, as I've said, NHS funding, workforce, pharmacy first, lots of technological changes, and also the whole law on how much supervision pharmacists need to supply. So how long do they need to be in the pharmacy? Do they need to supervise everything a pharmacy technician does? We've got COVID, we've got other things that could still happen that we don't even know about. So there's an awful lot going on. But the Royal Pharmaceutical Society, yeah, our strategic priority, because of all the changing that's happening, we've decided that our strategic priority for this year is prescribing. Currently, a quarter of pharmacists in Great Britain are prescribers, but as I've said, by 2026, all new pharmacists registering will be prescribers, and there's approximately 3,000 registering a year at the moment. But the big questions that we're asking ourselves and that we've got to begin looking for the answers for is, what does this mean for service development? If somebody's a prescriber, what services can they provide? Should they provide? What services will the National Health Service pay for? What will people pay for privately, if they will at all? What does it mean for pharmacists who aren't prescribers, who don't want to be prescribers? And what does it mean for regulation? So lots and lots of questions. So we have a lot to focus on because of all these changes that are happening. And I think it's wide open for research and what can happen, these massive, massive changes. I think we're lucky in the UK, in Great Britain. We have a lot of support from the medical profession for what we're doing, for prescribing. There's massive shortages of doctors, particularly in primary care. So they are very, very keen that pharmacists do more and that they work with pharmacists. So that's a really, really good thing. So that's a really quick run through. I hope it's inspired some questions and that you found that interesting. Thank you very much.
Thanks so much, Claire. That's fantastic. And I really appreciate how the end of your presentation with those three big questions sort of all tie back to that interface between research informing policy, utilizing evidence that's emerging. I think that that's a really important theme that's emerged through all of our summit events, going back even a few years. So I'm grateful for you bringing that up. Zubin, I think, has a quick question in the chat. He says, how is the pharmacy workforce, such as pharmacists and technicians, coping or adapting to the ongoing and unending stress of the National Health Service evolution? Oops, sorry, my screen just, more questions coming in. Evolution and the transition out of COVID. Is the Royal Pharmaceutical Society doing any focused work on workforce or system resilience in community pharmacy?
Yeah, thanks, Zubin. That's a great question. I think we've got a roundtable coming up on that with the charity called Pharmacist Support, who deal with a lot of the calls from stressed out pharmacists. But we've also done a survey, I think for the last 3 or 4 years, about workplace pressures and pressures on pharmacists. And we've been doing quite a lot of work around that. So yeah, I think it's really important. And, you know, there is an ongoing stress, and it's really, really hard. And as I'm sure it is in Canada.
Thanks, Claire. We have a couple other questions I'd like to get to in the chat from Yasmin. Thank you for the great presentation. How can community pharmacies integrate virtual care means like video conferencing, text messaging, or mobile apps into their daily practice? And how can community pharmacies ensure that their patients have access to the necessary technology and resources to engage in virtual care?
Thanks, Yasmin. That's a really great question. I think it's really hard to integrate it into running a busy community pharmacy, to be honest. So whether you need a separate pharmacist doing that bit within your pharmacy, I mean, obviously you can use text, you can have it all coming in, but how it depends how thick and fast those questions come in from patients, and video consultations and things. I think they can be incorporated, but I almost feel because of how busy, at least in the UK, pharmacies are, you would need a separate pharmacist to do that. I mean, we have got now some pharmacists do, some of the big chains have a sort of virtual presence as well, and others are just been set up as internet pharmacies. So it's a difficult one, I think, especially if you want to do it synchronously. If you want to do it asynchronously, you can take more time, I guess. But yeah. It's a difficult one, but I think it's a really important one. We're training our students at Nottingham to be able to do virtual consultations and video consultations, because I think that's really important.
Yeah, thanks, Claire. I think pharmacists here in Ontario and most of Canada are probably also in the same boat of being quite busy, and I know it can be challenging to integrate that into pharmacy workflows, but it seems like everyone's asking that question. So maybe next year we'll circle back and have more information on that.
Yeah.
The next question is from Katya. She is interested in your early statements about the link between better working conditions and the link to patient safety. This is a concern for the regulator here in Ontario and probably other regulators across Canada. Do you have research supporting this, or is your comment based on feedback you've received from pharmacists that you might work with?
Yeah, my comment isn't based on research, unfortunately. I think it's a wonderful research question, actually. It's just based on what I'm hearing and thinking about it. So yeah, sorry.
Yeah, no, that's interesting. Claire, have you noticed any sort of, I don't know how many sort of people you've talked to or received feedback from on that, but have there been any sort of themes or, general trendings?
I just think that people think that people don't get breaks, and we did quite a lot of work on that in the pandemic, and actually campaigned that pharmacists could shut because it was just crazy. So the contract here doesn't allow them to shut. They have to be open 24/7, not 24/7, but you know what I mean. Yeah. And so we got them to be able to shut for a couple of hours in the middle of the day during COVID, just to sort of take stock and cope. And I think, and that was linked to patient safety, and I think it's really important that, and I think pharmacists are stressed out, but some of them won't take breaks, and it's a really hard thing.
Yeah, it says a little bit about the mentality that people are also feeling that they have to bring to work.
Yeah, and I think they feel it, and then we have quite a lot of locums because of workforce crisis, so people are, they're covering, and they just want to earn maximum money, so they don't want to take a break, and they'll do these 12-hour days, and that really worries me, to be honest. Yeah. Because how can you keep going with that pressure, and the prescriptions and just everything be safe for patients? I don't know that it can be. I think it's quite.
Yeah, it definitely raises larger questions also just about sustainability of the workforce and where we're trending, I'd like to say post-pandemic.
Yeah, exactly.
I think we have time for one more question. So would just like to get your thoughts on Dharmesh Kumar's question in the chat about any thoughts you might have about community pharmacists' role in hospices in hospice situations or environments with advancements in technology.
I don't know if I know the answer to that one, Dharmesh Kumar. Sorry. I think most hospices, I think they get their medicines not from community pharmacy. I think they get them from hospital, but I might be wrong. I'm not sure. Sorry.
Yeah, if anyone else on the call has, suggestions or resources, I'm not sure where you're located, but we'd happy to be passing that around in the chat as well. I think I'll just read out Ernie's question, and then Claire, maybe I'll ask you to respond to Megan's question in the chat afterwards. Ernie was just wondering about the PIPS program in community pharmacies in Wales, if there were any lessons learned with initial uptake there.
Uptake by patients or pharmacies? I presume you mean from pharmacies. Okay, so it was done quite well because it started off in a small area of Wales, and the person who set it up, who's the chief pharmacist in Wales, he did it like a pilot but got everybody involved, and so the take-up was fantastic, and it's been really good as well. And I think it's just getting, as more and more patients found out about it, it's going better and better. Yeah.
Thanks, Claire. Just in the name of time, so we'll keep moving along for the day. I think if you don't mind responding to Megan's comment about differences between England and Wales, maybe in the chat, we'll keep that conversation going as we proceed with the rest of our event for today. But thank you so much, Claire, for setting the stage for us.
Thank you very much.
So I'd like to introduce our first presenter of our 4 research presentations for today. Rishabh, welcome. I'll invite you to put your slides on the screen whenever you have a moment. And I'll just provide an introduction for you. So Rishabh Sharma is a Master of Science student working under Dr. Tejal Patel's supervision at the School of Pharmacy at the University of Waterloo. He completed his PharmD in 2020 from India and worked as a research associate at the Health Economics and Outcomes Research Department. His research interests are gerontological and geriatric care. He has published several papers on the topic entitled Inappropriate Medication Usage in Older Adults in India in highly reputed journals. He has earned several awards at national and international conferences. We're very happy to have you with us today. I'll hand it over to you for your presentation.
Thank you so much, Annalise, for introducing me to the audience. Hi, a very good afternoon to all of you. My name is Rishabh Sharma, and I'm currently working under Dr. Tejal Patel's supervision at the University of Waterloo School of Pharmacy. So in this presentation, I'm going to present our scoping review titled Medication Reviews and Clinical Outcomes in Persons with Dementia. So here is my disclosure statement for this presentation, and I have nothing to disclose. So I will start my presentation with the introduction. Dementia is an irreversible and progressive syndrome in which an individual experiences cognitive decline in thinking, remembering, reasoning, and behavioral abilities to such a point that it may interfere with person's social and occupational functioning. There are over 55 million people worldwide living with dementia in 2020, and this number will almost double every 20 years. Given the population suffering from dementia globally, dementia is a burden for all healthcare systems because the patients with dementia had significantly more outpatient visits and higher economic burden than patients without dementia. So in this slide, I will give you a brief overview about why older adults with dementia are at increased risk of prescribing drug-related problems. So older adults with dementia often have high prevalence of comorbidities such as hypertension, diabetes mellitus, coronary artery disease, stroke, heart failure, due to which over half of older adults with dementia are prescribed 5 or more medication per day, which is also known as polypharmacy, to treat multiple morbidities. So the use of multiple medication and age-related physiological changes in older adults can pose a significant risk for potentially inappropriate medication use in this population. And at last, the use of potentially inappropriate medication and polypharmacy in older adults further increase the risk of drug-related problems, medication non-adherence, increased risk of falls, prolonged hospitalization, and economic burden as well. Drug-related problem, which is also known as medication-related problem, which I will refer as DRPs in the coming slide. It is an event or circumstance involving drug therapy that actually or potentially interferes with desired health outcomes. About 41% of hospital admissions in older adults with dementia thought to be partially or entirely related to DRPs, which is higher than the hospital admission in older adults without dementia. So here on the screen, you can have a look at one of the most commonly occurring drug-related problems in older adults with dementia. Moving on, prescribing in older adults with dementia is a complex process that demands regular review of medication to provide quality care to dementia patients. To provide you a brief overview on medication review, it is a structured evaluation of a patient's medicine to optimize medicine use and improving health outcomes. This entails detecting DRPs and recommending intervention to resolve these issues. The purpose of medication review is to optimize medication regimen by addressing the drug-related issues, the complexity of the treatment regimen, and the changes in the goals of treatment as the illness advances. However, there is limited evidence is available regarding the effectiveness of medication reviews in older adults with dementia. Moving on to the methodology part of my presentation, we used 5-stage framework developed by RC and O'Malley in this scoping review. The following 5 stages made up the scoping review. I won't go in detail explaining you about each and every step, but like our research question for the scoping review was to identify gaps in current knowledge about the impact of medication reviews on clinical outcomes and to identify the different type of DRPs reported in older adults with dementia. Ovid Medline, Ovid Embase, and Scopus databases were searched from inception to January 2022 to identify the relevant studies. Here on the screen, you can have a look at the inclusion criteria used in this scoping review to screen the study. The studies were in older adults having age 55 years or more, diagnosed with dementia or cognitive impairment, if the study referenced about a medication review, and if the studies were published in English were included in this scoping review. This brings us to the result part of my presentation. So as you can see through this Prisma flow diagram, we ended up including 22 studies in our scoping review. So this Prisma diagram is pretty self-explanatory about the steps in and the number of studies we have included or excluded at each and every stage in this scoping review. Moving on, we have divided the study on the basis of their study design and the type of care setting. So study design varied in this scoping review. So we identified some retrospective observational studies, prospective observational studies, audit, randomized control trials, and observational pre-post studies. On the other hand, the study were conducted in different care settings. Most of the studies, almost 9 studies, were conducted in long-term care settings, but we saw some studies from the hospital setting and community setting. And at last, we have also identified 2 studies which were conducted in both long-term care facility and community setting. And we looked at medication reviews impact on different outcomes. So a total of 54 outcomes related to medication review have been reported in 22 studies. 10 of the studies have reported outcomes related to drug-related problems, followed by 11 studies have reported outcomes on drug-related interventions. 16 studies have reported outcomes related to medication usage. And at last, 17 studies have reported secondary outcomes such as cost effectiveness, drug-related admissions rate, Cohen-Mansfield agitation inventory score, quality of life, level of agitation and pain, etc. Almost half of the studies reported on DRP pro outcomes. So here is a list of the criteria used in the different studies to identify and report DRPs in older adults with dementia. Although all the studies in this scoping review were published in the last decade, but no study used the latest version of PCNE criteria, which is published after 2010, to identify and report DRP. And I would like to highlight about one cross-section analysis that we identified in our scoping review. So the study was conducted on community dwelling primary care patients who were screened positive for dementia. The authors identified at least one DRP in 93% of the patients, and the authors reported a total of 1,077 DRPs in this population. So in this study, the medication review was conducted by the pharmacist. Moving on, 8 studies have reported outcomes on medication appropriateness. So we have identified some studies using explicit or implicit criteria to identify inappropriate drug use in older adults. BS criteria and STOPS criteria were one of the most commonly used explicit criteria to identify inappropriate drug use in older adults with dementia. And medication appropriateness index is the only implicit criteria used to identify inappropriate drug usage in this population. So all the criteria mentioned in this slide were not specifically developed for dementia patients, except one criteria, which is the only explicit tool specifically designed for patients with advanced dementia, and that is medication review guidance tool. So the table on the following slide highlights the 6 studies out of 22 studies, which shows that there is a significant decrease in either the total number of drugs prescribed or the average number of drugs per patient after medication review. So in most of the studies reporting a reduction in medication usage, the medication review was conducted by pharmacists independently or with multidisciplinary team. Let me give you one example. So the second study in the table, which is highlighted in yellow color, reported a reduction of 28% in the number of psychotropic drugs prescribed from 636 to 458 after the intervention. And this study also reported a decrease in the average number of psychotropic drugs prescribed per patient at 1 month follow-up. So the medication review in this study was conducted by a multidisciplinary team of physicians, pharmacists, and nurse practitioners. In conclusion, the scoping review highlights that medication reviews conducted by pharmacists independently or in collaboration with other healthcare professionals in any setting may have a positive outcome on medication use, reducing the number of medications prescribed, and identifying and reducing DRP among older adults with dementia. A reduction in medication usage was the key finding in this scoping review, and it is very difficult to draw a robust conclusion at this time due to the variability in the reported outcomes. However, some of the gaps were identified in the previous published literature through this scoping review. We have included total 3 RCTs in our scoping review, but no RCT was conducted in the community setting for patients with dementia. Only one observational pre-post study was identified in this scoping review for Canada, which was conducted on dementia patients from long-term care setting. So there is a need for more evidence for Canada, in which patients should be included from all type of care settings. And at last, there is a lack of studies examining outcomes such as medication management and adherence, cost effectiveness, patient and caregiver satisfaction, and quality of life of dementia patient as an outcome of medication review. So these are the few gaps that should be addressed in future research studies. I would like to thank you all for listening me, and if you have any question, please feel free to ask me. I will be happy to answer them. Thank you.
Thanks so much, Rishabh. That was fantastic. We're really grateful for you sharing some of the work that you've done. I'd like to open it up to audience Q&A. So if anyone has a question for Rishabh, please feel free to type it into the chat. Maybe just to get us started, I'd be curious hearing you pointed out a number of the sort of gaps that still exist. Do you have intentions with some of your work to carry forward in any of those areas you listed?
So yeah, that's a really interesting question. So I'm right now I'm in second year master's student, so I am actually doing study with Mint Memory Clinic in Kitchener and Waterloo area, and we are looking at the drug related problems using explicit and implicit criteria, and we are going to see how the prevalence of drug related problem in older adults with dementia in the next 1 year.
Fantastic. So maybe an opportunity to use a bit of your clinical background to supplement some of that research work.
Yeah, that's right.
Good. Wonderful. Well, maybe I'll invite anyone in the audience, if you do have questions for Rishabh, just to type them into the chat, either to the group or if you'd like to follow up privately. But thank you so much for your presentation.
Yeah, thank you so much.
Okay. So our next presentation is a bit unique. We haven't done this before at the Open Summit, but our next presenter is Lauren Cadel. Lauren had a class scheduling issue that prevented her from being live with us today, but she did provide a video recording of her presentation. So I'm just going to share that with everyone today. And I believe Sarah Gilcher, who is part of Lauren's research group, is with us today to answer any questions after we share the recording. So just wanted to say that. I'll do a quick introduction for Lauren, just so people online are familiar with who she is, even though she can't be here. Lauren is a PhD student in the pharmaceutical sciences area at the Leslie Dan Faculty of Pharmacy here at the University of Toronto. Lauren is supervised by Dr. Sarah Gilcher, who's joining us today, and her thesis work focuses on co-developing, implementing, and evaluating a toolkit intervention that aims to improve medication self-management among adults with spinal cord injury and dysfunction. Prior to starting her PhD, Lauren completed her master's in pharmaceutical sciences at the University of Toronto in 2019. Lauren is also a research associate at the Institute for Better Health at Trillium Health Partners, where she supports Dr. Carrie Kaluski's research portfolio on patient and family-centered care. So with that being said, I'm just going to share my screen again with Lauren's presentation, and we will take it from there. Oops. Bear with me one moment. Okay, perfect.
Hi everyone, I'm Lauren Cadel, and I'm sorry that I can't be there to give this presentation live, but I'm glad that I have the opportunity to share this work with you today. The title of my presentation is The Development of a Toolkit to Improve Medication Self-Management for Persons with Spinal Cord Injury, or the OPTIMAL-SCI project. I don't have any conflicts of interest to disclose, but before getting started, I would like to acknowledge my supervisor, Dr. Sarah Gilcher, my committee members, the working group for contributing to this preliminary analysis, the co-investigators on the project, as well as the funders for supporting this work. Persons with spinal cord injury or dysfunction, or SCID, are commonly prescribed multiple medications, including high-risk medications such as opioids and benzodiazepines to treat secondary complications and concurrent conditions. The number of medications individuals are prescribed increases significantly post-injury. And for most individuals, integrating medications into their daily lives is an unwelcomed consequence of their injury. Polypharmacy, or the use of multiple medications, is common among persons with SCID, with rates ranging between 31% and 87%. In this population, polypharmacy can be problematic and cause harm, with increased risks of drug therapy problems, avoidable healthcare utilization, and mortality. Adults with SCID have also highlighted significant challenges self-managing multiple medications, including the following: understanding and effectively integrating medications into their daily routines, managing emotions when dealing with complex medication regimens, controlling medication side effects, and effectively communicating with healthcare providers the concerns they have about their medications. Our previous research has highlighted the need for more support with medication self-management in this population. So what is medication self-management? For the purposes of this study, we will be defining medication self-management as the range of tasks, skills, and behaviors associated with an individual's capability, opportunity, and motivation to navigate the physical, social, and cognitive lifestyle factors, changes, and consequences inherent in taking or choosing not to take medications. These tasks include having the knowledge and related confidence to deal with medical, emotional, and role management, as well as the core skills listed here on the slide, which include problem solving, decision-making, seeking both formal and informal supports, self-tailoring, goal setting, optimizing social interactions, and engaging in activities, all as they relate to managing medications. So this brings me to the objective of the project. So this is a 3-phase mixed methods project, and it will address the previously mentioned challenges in order to improve medication self-management for persons with SCID. More specifically, we will co-develop, test, and evaluate a toolkit intervention that facilitates medication self-management for persons with SCID. For the purpose of this presentation, I'm just going to focus on the objective for the first phase of the study, which is to co-develop a toolkit to assist with medication self-management. Concept mapping will be conducted among adults with SCID, caregivers, and healthcare providers across Canada in order to identify key components of the toolkit. Concept mapping is a collaborative mixed methods approach that leverages participant-driven data collection and analysis. It is conducted in 3 sequential phases: brainstorming, sorting and rating, and mapping. The first phase is brainstorming, where participants create statements or ideas in response to a focal prompt or the main research question. And this will be done through virtual focus groups, one-on-one interviews, and independent online activities. As the statements are collected, as a research team, we will review and condense the statements by deduplicating in order to come up with a final list of statements for the sorting and rating activities. So the second phase of concept mapping is sorting and rating and involves 2 key activities. So the first is sorting, where participants will sort each of the finalized statements into groups or piles that are meaningful or conceptually similar to them, and then they will name each of these groups. The second activity is rating, where participants will rate each statement on a scale of 1 to 5 for how important and how feasible they think each statement is to integrate into the toolkit. The last phase of concept mapping is the mapping session. In this, a subset of participants will be invited to attend a mapping session where they are presented with a visual representation of the statements. Participants will have the opportunity to manipulate the map, and they will come to a consensus on the best groupings or clusters to represent the data. And once they've done this, they will assign a name to each group or cluster to represent the statements that are contained within it. So we are currently in the brainstorming phase of concept mapping. The focal prompt guiding these brainstorming sessions is, if a resource, such as a toolkit, was being developed to help persons with SCID manage their medications, what should it include? So to date, over 500 statements have been generated through the virtual focus groups, interviews, or independent online activities. And just a snapshot of the brainstorming sessions and participant characteristics so far. So I've conducted 9 brainstorming sessions with 22 participants. So 12 of these were adults with SCID, 3 were caregivers, and 7 were healthcare providers. And just to look at some of the demographics, 15 were female, 7 were male, and participants were from 3 provinces across Canada: Ontario, Alberta, and Nova Scotia. So far, statements have really focused on 2 main areas: the content to include in the toolkit, as well as how to deliver the toolkit. So when looking at ideas generated around the content of the toolkit, participants have discussed including the following information. The first, side effects and safety. So knowing what to expect, having a method for tracking side effects, and knowing what to do if experiencing side effects. The second being the tracking of medications, so including built-in reminders and strategies that other individuals have used that were successful for them. The third is including information on pharmacological and non-pharmacological options for managing common secondary complications. The fourth is including information on how to effectively communicate with healthcare providers, including key questions to ask and tips for self-advocating specific to medication taking. And lastly, information on accessibility. So things like medication delivery, pharmacies that are wheelchair friendly, and those that have specific knowledge about SCID. And when looking more specifically at ideas generated around the delivery of the toolkit, statements have focused on ensuring we have an individualized approach to delivery. So having the toolkit available both online and in hard copy, depending on what each individual prefers. Taking into account accessibility considerations, so the size of text, including read aloud functions, and limiting scrolling if it is online. The use of visuals, so including lots of pictures, videos, infographics, and pleasing colors. Healthcare providers have specifically talked about having access to a scannable QR code where they can quickly scan the code and bring up the toolkit when they're in consultation with an individual with SCID. And then lastly, the timing of delivery. So participants have talked about introducing the toolkit early in their journey, so either in acute care or in rehab, but making sure it's available as they progress. So looking at the potential impact of this toolkit. So medication taking has been noted as an extreme challenge for individuals with SCID, and there's a current lack of support tools. So this research presents an innovative solution to address this problem. Also, this toolkit will actively involve individuals with SCID in the management of their medications, which does have the potential to significantly improve their overall health and well-being. So just looking at next steps for this work, the plan is to continue with brainstorming sessions across the 3 participant groups. As a research team, we will start statement synthesis in order to finalize the statements for sorting and rating. So we are still actively recruiting and running brainstorming sessions. So if you're interested in participating or learning more, please feel free to scan the QR code on the slide or contact me by email. I'd also be happy to answer any questions that you may have. Thanks so much for listening.
Great, thanks. So hopefully the video and audio was okay. I think the audio was okay for me. The video seemed a little spotty at some points. It was fine when I tested it earlier, but if anyone has any questions, Sarah, I can see you're online. So thanks for joining us. And maybe we can have a little bit of dialogue just about Lauren's presentation. Maybe first question, Sarah, just from Dharmesh Kumar again, how long in terms of duration will it provide medications to SCI patients?
I'm not sure I understand the question completely, but I'll just say that the intention of the toolkit is to support people with their overall medication management, whether they want to take medications or not. It's we're taking a very holistic perspective on the concept of self-management. So the point is to help them with communicating with their healthcare providers in terms of any concerns or questions that they have around medication management. And we're not sure actually when it's going to be implemented or when it's ideal for folks to be introduced to the toolkit. And that's something that through the co-development with our working group and with what we gather with our participants to figure out, like, should this be introduced when individuals have sustained their acute injury during acute care? Should it be introduced in rehab if they go to inpatient rehab, or should it be introduced sometime once they've adjusted to they're transitioning to their next point, ideally returning to the community? So I'm not sure if I've answered the question specifically, but if I haven't, feel free to ask me again.
Thank you. Thanks, Sarah. Yeah, I think sort of as Lauren's slide pointed out, I think it's fantastic that there's just different perspectives that are coming to bear here to kind of get a more holistic picture of what might be helpful in terms of content and delivery. So I think that's fantastic. Maybe a question from Ernie. How will the concepts from the brainstorming be evaluated to be included in the toolkit?
Mm-hmm. Yeah, great question. So it's a very multi-phased process. So right now we're in sort of like design thinking. When concept mapping really integrates like principles from design thinking. So we're really interested in just generating like ideas from different perspectives that we would then condense down into a smaller number for individuals to rate in terms of importance. And that's really helpful for us to figure out, okay, so we have lots and lots of ideas, but in terms of where we go next and where we start with, we get perspectives from individuals then on those ideas in terms of rating, and we get a sense for what are sort of what we consider in concept mapping language, like the go zones, in terms of like what is sort of, we're getting good signals that this is an area that we need to move forward on. And we have a working group. So this is very much in partnership with people who have lived experience as either someone with a spinal cord injury, as well as clinicians from broad different perspectives. We have pharmacists, we have prescribers, we have just a very interdisciplinary working group to help support then the data that we've received from the sorting and rating stage, to also complementing it to the recommendations made by our working group. And really by integrating these different sources of information, we will then start developing the toolkit, which For time restraints, we didn't have a chance to kind of get into, but we'll be doing cognitive interviewing. We'll be piloting the prototype of the toolkit as another phase of Lauren's PhD work. And then we will do initial implementation work where we're assessing sort of the feasibility of the toolkit as a preliminary evaluation.
That's great, Sarah. Thanks. Lots to come, clearly.
Lots to come. And if you'll have us back again, there'll be many years probably of sharing where we are in the evolution of this work.
Yeah. Well, thank you so much. Very, very grateful that you could join just to kind of supplement some of the things Lauren shared in her presentation. So thank you so much.
Great. And thank you for accommodating and allowing her to share her work while she's also doing the other requirements of her PhD, which is taking courses. So thank you.
Yeah. No, thanks so much, Sarah. Fantastic. So I'd like to turn now to our third research presentation for today. Andrea, welcome. I'll just get you to share your slides whenever you're ready, and I'll introduce you. So Andrea earned her honors of Bachelor of Science from the University of Toronto and is currently pursuing a Master's in Pharmaceutical Sciences at the Leslie Dan Faculty of Pharmacy here at the University of Toronto, while also working full-time as a research and education coordinator. Her research interests involve supporting interventions and collaborative practices that can improve mental health care delivery and medication management in pharmacies, and specifically with post-secondary students. Thanks so much for joining us, Andrea, and I'll pass it over to you now.
Thank you, Annalise. Thank you everyone for joining in on my presentation today, where I'll be talking about my master's thesis project, which is exploring the pharmacist's role in supporting post-secondary students with psychotropic medication management. I have no conflicts of interest to disclose. I would like to mention that this research is funded by the University of Toronto Leslie Dan Faculty of Pharmacy and also the InLight Student Mental Health Research Initiative. So I'll begin by talking a little bit about my study population. So the term emerging adulthood, which is my population here, was coined by Arnett, who is a psychologist in the USA, and defines young adults between the ages of 18 to 25 years. There are a significant number of emerging adults entering post-secondary institutions. As you can see from this graph from Statistics Canada, that number has steadily increased each year. It's during this period of life that qualities to become successfully self-sufficient and make independent decisions for oneself are being developed. There's not enough preparation when leaving the era of youth in multiple areas, and that includes healthcare. Ontario's healthcare system in Canada is spread across so many different areas that sometimes it can be hard to navigate, and the systems do not work in silo. They're not coordinated in a way that is built to help support this age group. These headlines are just a snapshot of the mental health crisis on campus. Findings from the National College Health Assessment conducted in 2009 stated that anxiety and depression is the most prevalent diagnosed mental illnesses among Canadian post-secondary students. There's an increasing demand for mental health resources on campus. Yes, this is a post-secondary student issue, but also a community issue, a societal issue. It all ties together. There's tremendous reporting of stress from a post-secondary environment that students are experiencing. Mental health resources do exist on campus, and here at the University of Toronto, they've been doing a great job in introducing new programs, but psychotropic medication management, which is one of the tools that is used to help manage mental illness, has not yet been introduced. So going through life changes and transitions places post-secondary students in a unique area of life where emphasis on the promotion of mental health alongside treating symptoms of mental illness might require more age-specific related care. So why is this research important then? When students obtain prescription psychotropic medication from pharmacies, there are opportunities to support them with their medication use and promote mental well-being. There's a need for pharmacists to move towards a better approach to connect with and better support post-secondary students. The question of how pharmacists can provide psychotropic medication management support to meet the needs of students remains unanswered with limited exploration of this. So that brings me to my primary research question, which is what experiences do post-secondary students describe with psychotropic medication management, and what do they identify as needs? And there are two secondary questions for this research. The first is how can pharmacists support post-secondary student psychotropic medication management needs? And the second is how can digital technologies be optimized to help pharmacists support post-secondary student psychotropic medication management needs? This study design will follow descriptive, interpretive, qualitative research. The study will use purposeful snowball sampling method to recruit participants. So what that means is after the first few interviews, the participants will be asked to share the study details with others in their circle who they think might be interested, and the snowball effect will continue until data saturation. It's expected that a total of 20 interviews will need to be conducted for this study. With that being said, a process of ongoing interpretation of the data will occur as the study proceeds to identify a point when data saturation is achieved, meaning no new information or new themes have emerged from the interviews. The data collection, as I mentioned, will be conducted through semi-structured interviews, and analysis will result in detailed descriptions of what and how students experience self-identified psychotropic medication management needs. The resulting statements and themes will then be used to develop the description of the student's experience and how pharmacy can help fill the gap. Here is just a diagram of my progress to date. So I'm currently in the data collection, data analysis phase. Participants were identified through recommendations and outreach by University of Toronto campus student-led group representatives, and also through recruitment efforts with health centers on campus. So this included posters being put up, email invitations being sent out to listservs, social media posts, things like that. So with all that recruitment, I currently have 15 participants enrolled in the study. So that means that they met the inclusion criteria and we were able to complete an interview. To be included in the study, participants must have been a student at the University of Toronto, have a self-reported diagnosis of a mood disorder such as anxiety or depression, and must have taken at least one psychotropic medication to manage a mental illness in the past 12 months. So if an interested participant clicked on the link or found my poster, they reviewed the consent form and details on REDCap, completed screening questionnaire, and then participants who met the inclusion criteria were invited to an interview. So this is where I currently am right now. Data analysis will be iterative and reflexive. And so what that means is I complete 2 to 3 interviews a week, following week used for analysis and make any changes to the interview guide, with the following week used to go back into the field. The analysis will follow the process described by Braun and Clark for inductive thematic analysis. A benefit of thematic analysis is its flexibility as a method for identifying, analyzing, and reporting patterns. Inductive analysis is appropriate for this study as it will involve coding the data without using or trying to fit it into a prior coding frame. Rather, the codes will be data-driven. And this is because the research topic under investigation is under-researched and the participants' views on the topic are not known. Therefore, rich thematic analysis of the entire data set will result in an accurate description. So I'm currently in phase 1 of my coding. I've divided my data analysis into 3 phases. And so I'm currently in the initial coding phase, where this involved cleaning up the transcripts, printing them out, and highlighting by hand notable codes. The next step is phase 2, which is the in vivo deeper analysis. So uploading all of my transcripts into a software called in vivo, used for qualitative research analysis. And using in vivo, I hope to do some deeper analysis to identify trends and develop a thematic framework. And as I mentioned, an inductive thematic approach is being taken for the analysis, which means that the themes will be strongly linked to the data. And then phase 3 will require refining the themes, rereading the entire data set to confirm that the themes work, and then looking at what codes are related to each other, how are they related, why are they related, and what does this relationship tell me about the research question. So I'm in the early phases of my analysis, but I do have some really early preliminary results to present. If we have the chance to meet again in the future, I probably will have a bit more results to present, or they might look a little different. But right now, based off of the interviews that I've conducted so far, my results have really fallen into 4 big buckets, which are mental health management, medication knowledge, digital tools, and pharmacy experience. So initial interviews have found that participants often seek psychotropic medication information on the intranet, which would be no surprise, due to a lack of information or gaps remaining in knowledge despite interactions with healthcare providers. Participants expressed the importance of understanding safety, efficacy, adverse effects of medications from healthcare providers, but then also feeling like a bother sometimes when attempting to talk to them because they just seem so busy. Participants also shared feelings of being unheard when communicating about mental health with a healthcare provider. So I don't have, just with time constraints, I won't go through in detail all the bullet points here, but I did want to mention some. Under mental health management, participants described using alcohol, other substances for relief from stress to help manage mental health, but they also mentioned that they feel like they don't receive enough information about the effects of these with psychotropic medication. So for example, some medication directions might say limit alcohol consumption, but what does that really mean? Under medication knowledge, participants described wanting to know more about why a certain medication was chosen over others. There are so many psychotropic medications out there. Why did the prescriber choose this one over others? So just getting more into the details of that. Under digital tools, seeking health information online was huge. Using the internet to find answers about health, including mental health and psychotropic medication, using published tools, websites, social media. Participants also mentioned that reading or seeing other people going through a similar experience with their mental illness or mental health journey led them to feel less alone. And so that's why they tend to go to the internet a lot to find that community. And with that being said, under pharmacy experience, with all that taken into consideration, participants described wanting a more holistic approach to medication to manage their mental health, their mental illness with everything else that's going on right now. And they find value in receiving this information from a pharmacist, sitting down with them for a few minutes and talking about it. So that leads me to the end of my presentation to talk about a bit about the significance of this study. So this study will investigate strategies that can be implemented in pharmacy to offer psychotropic medication management services to students and address how to target medication management concerns experienced by students dealing with mental illness in the pharmacy. I would like to mention that this research is not being conducted in isolation. So that being said, student-led groups, as I mentioned, they've informed recruitment materials and efforts. Healthcare centers on campus at the University of Toronto have also supported recruitment of the study. They know about this study and are also aware of the work being done. In addition, there's conversations with the faculty's associate dean, academic and strategic initiatives director that have situated the real-life application of the study results. So the study set up well to be taken up locally, starting off at the University of Toronto and then hopefully branching out. And thank you so much for listening. I'm happy to take any questions. I would like to say a quick thank you to my thesis supervisor, Dr. Lisa Dolowich, and also my thesis advisory committee, Dr. Beth Spruill and Dr. Kristen Cleverly, who've been integral in guiding the direction of this study. Thank you.
Thanks so much, Andrea. Fantastic to hear more about the work you've been doing, and obviously so important, especially for a lot of people on this call who might be current students themselves or working in an academic environment. So I'm sure that the findings you presented and future findings will be of great interest to those people. Barb Farrell just had a question for you in the chat. Her question was, any themes arising with respect to the experience of students with medication side effects?
Yes, so that actually is a bucket that I have been seeing coming up in conversations. And so in terms of adverse effects, participants have described adverse effects coming up from taking psychotropic medications, but then not knowing how to manage that with their everyday life. For example, one participant had mentioned that the medication that they were on, they were steady for a while. And so the prescriber had increased the dosing, but then that brought along some night sweats. And so every night the bed was drenched, she had to change it. And so that was a lot of lifestyle changes that when trying to have a conversation, didn't really know where to go. And so it's even managing of those adverse effects with these medications. I found that participants are a bit struggling of where to talk to, who to talk to. And so they find turning to the internet a lot. And of course, we know the internet has to be taken with a grain of salt as well. It has a lot of information out there. And so it's sometimes hard to navigate. And so that was one of the main things that came out from adverse effects, knowing just why it's occurring and how to manage that even.
Great, thanks, Andrea. And just another question. I think you kind of explained this at the beginning of your presentation about selecting sort of emerging adulthood as your target population, compared to middle age, et cetera. And yeah, just want to know if you wanted to speak any more about selecting that population and sort of if you think that those experiences are very unique compared to, say, someone who's 26 or 27 or slightly above that age group.
Sure. Yeah. So as I mentioned, that's a unique period of life between 18 to 25 years. And so age 17 is usually, or 17, 18 is usually when adolescents are graduating high school and moving on to this new period of life where they're trying to figure out what their next steps are. Some might entail moving out of their parents' house, navigating the healthcare system for the first time, navigating other things like going to the bank and, making their own appointments for the doctor, things like that. So being an adult for the first time. And I think that can put a lot of pressure where all of a sudden you're dropped into this new form of adulthood and you have to figure it out on your own. And so that places emerging adults at a unique period of life. And as I mentioned, there's not really a transition between youth mental health services and then adult mental health services. It's if an adolescent is part of a youth mental health program, there really isn't that pathway to now figure out where to go to when you have questions in more of the adult focused mental health programs. And so that sometimes can result in people not knowing where to go. So then they completely stop caring about their mental health or how to manage their mental health. And so sometimes people fall off like that. And some of the challenges experienced include things like that. I think also in my conversations with participants, I found that stigma is still very much present in talking about mental illness and mental health, and then perception of other people around you as well. That could play into it. Coming into an academic environment for those of us who are students could be exams, a lot of different things that add to stresses. And so things that are different than those who are perhaps 25 plus, who now maybe have graduated school or starting a life, get married, different life instances occur. And so it really places emerging adults in an interesting space.
That's great, thanks. And I think Ernie had a bit of a follow-up question about any surprising themes. I think you mentioned kind of the stigma piece. Anything else that kind of stood out to you from your initial interview analysis?
That is a great question, Ernie. Definitely. I think one of the big ones that was a surprise, but then also at the same time, I guess it wasn't, was the digital tools. Seeing or hearing about people's interactions online and how that much affects their day-to-day life, that was very interesting. But one of the big interesting forms about using online digital tools or seeing other people's experience on social media was that participants had mostly expressed to me that they prefer to read someone's experience. So let's say on like Reddit or like a thread like that, where it's more of a conversation, than watching videos about health, which I thought was interesting because TikTok is so big right now, but maybe it's more used in the younger generation. But it was that was really interesting to me because I perhaps would have thought that TikTok or watching videos about how to manage mental health or watching other people going through the same thing might have been a bit higher. So I was very interested to hear that participants had expressed reading about experience and being involved in a community that way more so than the videos. That was something that was interesting.
Thanks for sharing, Andrea. If anyone else has any questions for Andrea, I'll just invite you to follow up in the Zoom chat box, but thanks so much for sharing your work with us.
Thank you.
I will now invite our fourth, final, but not least research presentation for the day. Diya, if you want to put your slides up. I'm just searching, yes, for your name. Perfect, thanks. I think I saw you join. Thanks so much. I'll provide a quick introduction for you. Diya Srinivasan is a research associate at the Institute of Better Health at Trillium Health Partners, where she leads a multi-site 3-year CIHR grant to understand and improve variation in care delivery, drawing upon disciplines of implementation science, specifically audit and feedback, organizational behavior, and management science. She's previously supported virtual care and policy implementation projects. Diya has a Master's of Science in International Health Management and has over 6 years of experience as a healthcare researcher and strategy consultant. She's advised various healthcare stakeholders, including pharma and biotech, healthcare providers themselves, digital health innovators, and public health organizations. Having lived and worked across the United States, the United Kingdom, United Arab Emirates, India, and now Canada, she has gained exposure to a range of health systems, allowing her to leverage global insights in her work. She's passionate about developing innovative models of care to improve care equity and system efficiency. Thanks so much for joining us, Diya. I'll pass it over to you.
Yeah, thanks so much, Annalise. Thanks everyone for joining in on this presentation. I'm quite excited to chat about it as it's rather topical. It is about the resources and supports required by pharmacists with minor ailment scope expansion policy that just came into effect on Jan 1st of 2023 across Ontario. Before I begin, I have no conflicts of interest to disclose. I would also like to note that my colleague, Dr. Yasmin Aziz, is on this call, and I would encourage her to speak up whenever she'd like or field any questions on the chat if it comes up. So what I'm going to talk about today, the resources and supports that pharmacists have identified they will need to help them safely and effectively implement the minor ailment prescribing policy, is actually a part of a larger study called the Ontario Program to Improve Antimicrobial Use. It is a one-year grant funded by CIHR. We have an incredible team, and all their names are on the screen in front of you. There is a ton of material to cover, and I'm really excited to go through all of it. So do forgive me if I am speaking a little quickly. So in terms of our methods, specifically for this segment of our work, we spoke to we conducted 24 virtual one-on-one interviews with pharmacists, as well as reviewed 71 online surveys to gather pharmacist perspectives on the minor ailment service provision across Ontario. Our interviews were audio recorded and then transcribed verbatim. Inductive coding through NVivo was used to identify common themes and recurring patterns. Our data collection tools, i.e. the interview guides and the survey, and the data analysis were guided by the theoretical domains framework, as well as the consolidated framework for implementation research. As I mentioned, however, the OPTIMIZE project was a larger project that looked to understand the facilitators and barriers of the MA scope expansion policy. And as part of that work, we also conducted focus groups with patients and physicians. However, we did not explore pharmacist supports with them, and so their insights have been excluded from the presentation today, which is to say everything that I will be covering is from our pharmacist interviews. So our findings allowed us to identify and contextualize 26 individual support items that we then categorized into four categories: clinical supports, education and training supports, workflow supports, as well as professional supports. So a quick overview of the pharmacists we spoke with. We spoke with 24, this is just the interview number. So a good balance across the years of practice, the community size, the pharmacy types. So I'm going to leave that on just for everyone to quickly look at. One of the things that really stood out to me and to our team was just, the sheer amount of overburden. We see that majority in terms of the prescription volume per day are above 100. Nine of the 24 pharmacists noted above 2,400 to 2,200 in terms of the prescription volume per day at the pharmacy. And then if you sort of look at the number of pharmacists that work at those pharmacies, you have 12 pharmacies with 4 or more. However, if you look at how many pharmacists actually work alongside others, 12 have no one that they work alongside, 4 have one other, and definitely the minority having 2 or more pharmacists. Sort of really speaking to overburden being experienced. So a lot of the supports that we will be looking at have been well identified to be relieving a fat burden, as well as to improve the efficiency of the care that can be delivered. So starting off with clinical supports. The first one was noted around pharmacist access to diagnostic testing, access to relevant clinical testing tools to confirm diagnosis at point of care, like bacterial versus viral strains, kits to test strep throat, urine culture strips for UTI, etc. Next is pharmacist access to patient information. This was a really big one, consistently mentioned by every pharmacist we spoke with. The desire was almost this ideal of logging into a single gateway portal, a single gateway platform like Clinical Connect or eGTA to access patients' lists of current and previous medications, allergy, any past medical history that can be significant, and to sort of have access to patient information across Ontario rather than just the patients that have visited that particular pharmacy before. An example that was cited was PharmacyNet, a software used by pharmacists in BC. Next, standardized urgent care processes for patients, appropriate mechanisms to manage adverse effects, allergies, etc., whether at the pharmacy or after the patient goes home. And I think this theme of pharmacists being able to think ahead and sort of always think about the well-being of the patient constantly comes out as we kind of go through supports. And you can really see the kind of foresight around that deep patient care that comes out. Similarly, with patient handouts and information resources for patients, for them to be able to hand them out and take them, that patients can take home. So any teaching material or handout that pharmacists can give patients at the point of care that provides education on the condition, the minor ailment condition, prescription, and recovery monitoring for each of the minor ailment conditions. Next, around a direct support line for pharmacists, which is a pharmacy level subscription to a support line, for example, clinical diagnosis resource from the OPA, the Ontario Pharmacists Association, to provide pharmacists access to all literature and knowledge and be able to support with a knowledge check. Lastly, standardized guidelines for minor ailment management. They would like guidelines for each minor ailment, symptoms, and treatments, i.e. a chart with all the first line treatments and alternative treatments available at the point of care. And they made and pharmacists made a point to note that these educational models, these guidelines should be as closely aligned as possible with those that physicians and nurses work with to ensure a level of consistency for patients across Ontario. Some interesting quotes that, for the sake of time, I won't be able to quickly go through, but I'll give it a second for anyone who's interested to read. Okay, going on to education and training. So a very interesting thing that came up was having a joint seminar, during these initial months with the OCP as well as the OMA, the Ontario Medical Association. And I think this point was largely so that pharmacists and physicians could come together and be able to be briefed by the governing body so that everyone could be on the same page. One of the points that came up, or like the underlying tension that was there that pharmacists felt, was how the current prescribers and how their physician partners might sort of take on the scope expansion policy by pharmacists, and they wanted to be able to have a very collaborative initiation of the policy. So a seminar with the two groups to explain and align expectations around the new scope of practice for pharmacists, and clear messaging around the scope, expected challenges, troubleshooting, and resolution options. Pharmacists were very emphatic about having clarity in the overall healthcare system about the policy and their responsibilities. Next, CMEs and training specifically on the 13 minor ailments, and the courses to be able to cover diagnosis or confirmation of diagnosis, therapeutic choices, warning signs, and the best course treatment for each of these 13 minor ailments. Veteran pharmacists particularly expressed interest in this, while we noted across our pharmacist population that the younger ones felt far more confident being able to sort of come in and take this up as their regular course of work. Third, under education and training, we have patient communication and consultation training, training for effective patient communication around confirming diagnosis and talking and discussing therapeutics. Some of them even mentioned that they would like to develop their skills in terms of communication, developing trust, and managing patient relationships over time. And again, veteran pharmacists expressed their particular interest in this. Fourth and lastly, on education and training is patient vitals and a general assessment training. To be able, pharmacists wanted to learn how to check breathing, pulse, temperature, blood pressure, etc., to be able to sort of do a check, a general vitals check. And while it may not be specific to MA, they wanted to be able to have these skills on hand as part of coming into contact with patients on a more intimate and on a more intimate level. Going into the next one, which is workflow supports, which was again mentioned by everyone to some degree that we spoke to. Starting off with communication, there was a lot around wanting to be able to immediately contact patients if needed, just in case anything were to go wrong. They wanted to be able to have, they wanted to be able to give patients the ability to contact them in a fairly instantaneous fashion. Similarly, for pharmacists to be able to communicate with physicians, and again, pharmacists, I think, had the sense of, oftentimes physicians are trying to contact pharmacists and it ends up going to a generalized pharmacy line, and they know that physicians find that quite frustrating. So they sort of made a note, especially with this minor ailments expansion policy, that physicians in this case should be able to get to a pharmacist very rapidly. And so that was sort of noted as being able to develop communication, more direct communication lines for patients and physicians to reach pharmacists. Next, around documentation, and in a more idealized sense, I think pharmacists were envisioning an EMR module, like an electronic medical record module specific for minor ailment prescribing, which allowed them a standardized patient assessment form and a patient follow-up form that allowed them to very clearly document the symptoms, the confirmation of diagnosis, any assessments done, as well as the medication and the course of treatment prescribed. That could then be, in a very unified way, be shared with patient providers and anyone else who needs it in the healthcare system. And of course, moving from communication and documentation to more logistical aspects of providing consultation is space. The pharmacists were very sort of cognizant of the nature of these consultations and requested dedicated private consultation rooms. While some pharmacies obviously might already have this space, some pharmacies don't, and this would be kind of imperative to ensure patient confidentiality and also the pharmacist and patient comfort in terms of having a conversation. Staffing, of course, not a whole lot I would need to say here, but an interesting point that was made more than just we need more staff is having very clear role allocations and having specific, whether it's pharmacist assistants to help with dispensing, while the pharmacist can focus more on this, these more expanded scope items and being able to interact with patients one-on-one. So not only just having more staff, but having more of different types of staff that are able to take on different types of functions, whether it's dispensing or doing med checks or doing patient and provider communication. It's also like the clarity of role allocation that pharmacists indicated was important. And lastly, of course, time, having dedicated consultation hours and staff to maximize the ability for pharmacists to take up the MA prescribing services, as it's very difficult to do this completely in parallel to their current roles. in terms of OTC consultations, prescription pickup, drop-off, etc. And they really would like a patient-facing system for MA consults where patients are able to almost book an appointment or at least put themselves on a wait list, and patients have an indication of how long it might take for them to come in. So as I mentioned, a lot of thought around making the process and the workflow easy for patients to effectively take up the service, and for pharmacists to not feel extremely stretched or stressed out in that moment. And for patients to also, as part of that sort of online booking system, be able to get sort of all the information, the disclaimers, what they can expect when they go in to talk to a pharmacist, that kind of information as well. So, just in these like sort of 40 to 50-minute interviews, a lot of thinking around every moment of this patient care experience, which was extremely incredible to be able to hear. Lastly, around professional supports. Of course, the first thing was around how they wanted to ensure that there was an evaluation, a continuous evaluation of the scope expansion policy implementation. And pharmacists indicated they wanted to be able to evaluate and monitor the effectiveness of the MA policy to ensure quality and safety of prescribing, appropriate antibiotic stewardship, opioid prescribing as well, feedback to pharmacists across Ontario. And it was noted that pharmacists currently don't fully know how other scope expansion policies have fared. And this was, a big gap in this kind of extended work that pharmacists are engaging in, to be able to really know what are the benefits and how it's supporting the system and what they need to do differently. Next, at a more pharmacy level, have a practice evaluation, on a month, setting up a standardized internal peer review process to improve pharmacist behaviors, ensuring the right drug to indication match, increasing clinical thought and refinement and decision-making to improve the pharmacist's confidence in minor ailments and antibiotic prescribing over time. So being able to have a debrief at the end of the month with their colleagues and discuss cases, discuss what was challenging, how people are going about taking up the policy. Next, on kind of requesting collegial support, minor ailment policy champions, as well as OCP-backed peer-to-peer groups. Most pharmacists work alone, and having peer champion support groups and opportunities to connect with other pharmacists would be extremely valuable and a great motivator for increased uptake. Next, we have community awareness and messaging on MA policy, as well as the pharmacist role appreciation. So a lot of pharmacists expressed that they felt that their role was not fully understood by patients as well as the healthcare system at large. And there has to be improved messaging to add to the integrity of the role and the trust in the role, especially if pharmacists are going to be prescribing to patients. So they want to be able to not just build trust independently, but have a system that supports them to be able to get the trust of prescribers and patients. So appropriate messaging and community awareness around what the pharmacist's role is, how they are medication experts, and what they can do to support patients, given this minor ailment policy. Of course, financial compensation, it's sort of in the middle of the last point, but I think if this team had their way, they would put it right up front. Pharmacists have been constantly engaging in more and more expanded scope policies. And I think when this concept of prescribing and confirming diagnosis came up, every pharmacist said that it would be extremely important to offer monetary compensation through a fee-for-service model for as they are taking on additional work that would be previously done somewhere else in the system and would be compensated. However, again, the foresight of having the awareness that there can be a conflict of interest to be a role in a pharmacy that would be interested in, of course, increasing its prescription volume. And so they have suggested in developing an incentive structure that allows fair compensation for the pharmacist, but to combat the conflict of interest between this role and the entity or the corporation of the pharmacy. Interestingly enough, not mentioned too often, but a few pharmacists mentioned that some sort of like legal protection or some sort of protection as pharmacists begin prescribing, to ensure that, you know, if there are grounds for patients to complain, or if there are any cases that might come up that might be complex, to have some sort of recourse and have some sort of support in the system that will help individual pharmacists manage that process. And last and very important is just mental health support and having time off when pharmacists need it. There is an extended huge amount of burnout and stress and overburden and exhaustion that pharmacists are feeling. So being able to take up additional responsibilities, you know, they've indicated should go hand in hand with compassionate practices at the pharmacy and at a regulatory level. I will stop there and thank you all for listening to me speak. I'm very excited to answer any questions, and feel free to reach out to our team as we present more of the optimized work. Thanks a lot.
Wonderful. Thanks so much, Diya. An incredible amount of work has gone into that. I think just even those four sections in each of the sort of subpoints beneath each of them really speak to the work that you and your team are undertaking, which is really, really wonderful. There was a comment in the chat from Anne. I'm not sure if you want to speak to this at all, just about how prescribing for minor ailments is different from what was happening prior with minor ailments, such as pharmacists recommending over-the-counter products. I don't know if you want to comment on that.
Yeah, I can quickly mention it. So now, so prescribing for minor ailment is, I think, different because now these are prescription grade products that pharmacists can prescribe for minor ailments. So not just OTC, they will be able to prescribe certain antibiotics for the certain minor ailments as part of the list of 13. So products that physicians would previously be able to prescribe, now pharmacists will be able to prescribe, or are able to prescribe as of Jan 1st as well.
Yeah, that's great. Does anyone else in the group have any questions for Diya? I'll maybe just give it a few more seconds before we wrap up for the day, but thanks for putting your contact information on the screen, Diya. That's helpful if people want to follow up with you as well. Okay, if no further comments from online, Zubin, I will put up our final sort of screen highlighting a few closing statements and turn it over to you for those final remarks.
Perfect. Thank you so much, Annelise. But first and foremost, thank you to all of our speakers today for presenting your very important research and sharing the work that you are doing with our broader pharmacy community. I hope for all of you in the audience, it's an opportunity to see all that OPEN is actually doing. If you'd like to learn more about OPEN, as you can see on the slides here, please connect to our website and join our Facebook page and join our mailing list if you would like to hear about more events, including an event we're planning for the fall, a live, finally, version of this Open Summit, for an opportunity for us to really engage in some networking and opportunities to reconnect with one another or connect for the first time with one another since the pandemic. Next slide, please. As mentioned at the opening, in this summit series has been produced by Annelise Mathers and the Center for Practice Excellence. So please join us at the Center for Practice Excellence for our variety of different speakers events as well. To join our mailing list, you can just click on the link here, and we look forward to seeing you at future Center for Practice Excellence events. A final slide, please, before we conclude for today. So thank you to the many people involved in organizing today's event, but most importantly, a very big thank you to Annelise. Organizing events like this might seem simple in an online world, but Annelise puts in countless hours and an amazing amount of dedication to helping us learn from one another. So thank you so much for all you do for us, Annelise. And a very big thank you to all of you who have stayed with us and participated so actively in today's session. This is, of course, the entire point of an event like this, so thank you for coming out and contributing your thoughts. We will say goodbye to you for now and look forward to you joining us at a future open or CPE event. We hope you all stay well, and thanks for joining us today.